This third session of the IANPHI annual meeting will focus on pandemics, conflicts, climate change. What have we learned from the past 3 years? And we will have 6 presenters in this session, of which 4 are case studies. And we will have 2 from the African continent and 2 from Europe. And 2 are joining us remotely, and 2 of the panelists will be present here in Stockholm. But we will start with a presentation by Scott Pendergast, followed by Annika Veimer, and then we will go into these 4 case studies that I will introduce in just some minutes. But before we start the session, just some housekeeping rules again, that you have heard some of them already. And that is that we also have a lot of participants online, and they should feel free to use the chat to share their comments and ideas related to the discussions. And later in the session, if you want to make questions or comments for the online presenters, use the Q&A box. And for those in the room, we will have, after the 4 presenters with the case studies, a Q&A session. But after the 2 first presentations, there will be some time for comments and questions. And then, please, if you can then raise yourself and give your name so we all know who you are. There will be 1 presentation in French, and there will be interpretation then to English. And for the English presentations that are the rest, there will be live interpretation to French. And all the sessions of the meeting will be recorded. And something new for this session is that in line with the WHO guidelines on physical activity and sedentary behavior, we will have active applauses, which means that when a speaker has presented and you give the applause, I want you all to stand up, because this is a 1 hour and 30 minutes presentation, and you've all had lunch. And for us now it's afternoon, and I know a lot of you have traveled from quite far, and we have presenters with us digitally that have maybe morning or later evening. So in line with the WHO guidelines, I will encourage you to have active applauses with standing up, but I will remind you as we get there. So, coming to the session, as was concluded in the UN Sustainable Developmental Goals report this year, that was released this summer, it was stated that the convergence of violent conflicts, COVID and climate crisis, they jeopardize the global goals. And these intersectorial global crises are really threatening the SDGs and impacting both food supplies, health, as we all know, education and security across countries worldwide. And according to the report, this convergence of increased fighting, the continuing COVID-19 pandemic, and the long-term climate crisis, they are modulated to potentially push an additional 75 to 95 million people into extreme poverty. And we know that the ability to have the livelihood is one of the most important determinants of health. And this is compared to the pre-pandemic projections. So there is a risk that they will jeopardize the SDG blueprint for more resilient, peaceful and equal societies, all these converging crises. And has been pointed out also by the UN, not only the impact of the crises are linked, but so are the solutions. And that's why we today will not only focus on the crises as such, but we will also listen to what we have learned from the crises. And with that, I would like to introduce Scott Pendergast, and Scott will make a presentation on the new architecture of the emergencies. And Scott, as many of you know, is the director of the Strategic Planning and Partnership in the Office of the Executive Director of the Health Emergency Program at the WHO headquarters in Geneva. And you're also currently responsible for the overall strategy, the program delivery and the strategic partner engagements to prepare for, prevent, detect and respond to global health emergencies and humanitarian crises. So with that, I give the word to you, Scott, on strengthening the global architecture for health, emergency preparedness, response, and resilience. Please.
Okay, thank you very much. And it's a little bit suspicious that the new WHO guideline on standing up and applauding comes just as I present. Very unintentional. So thank you for the opportunity to present today. Have I got the right? There we go, yes. And this session's about building on the lessons learned coming out of COVID, and how do we take those lessons and look forward to the future to getting a strengthened global architecture for health emergency preparedness and response. As we know, COVID continues to have devastating impacts, not just on health, but on our economies, education, climate, poverty. SDGs was mentioned. And what we're seeing over time is both an increasing frequency and an increasing impact of epidemics and pandemics. In fact, many times more than current global health crises such as HIV, TB, and malaria. But also, as was mentioned in the opening, we're also seeing increased both geopolitical crisis as well as climate-related disasters. With now, I think the latest number in the humanitarian report was 350 million people globally in need currently of humanitarian assistance. And so we're really in unprecedented times, and we really have to rethink a lot of the lessons learned. It's not throwing out what we've had before, but it's certainly learning those lessons and building on what we've got. One of the biggest lessons that we've had, and it's been mentioned again and again and again in the last couple of days, is that health emergencies aren't just about health. They're a whole of society, a whole of multi-sectoral approach, both in terms of their causes as well as their impacts. So causes in terms of looking at the animal health, agriculture, environment, looking at the impacts in terms of the economic, the social, welfare, protection, and then the integration that's needed beyond health emergencies into disaster management and national security. Similarly, what we've heard is that health emergency preparedness and response doesn't sit outside the health system. In fact, it's very much within the health system, and it has to be built off that. And in particular, this integration between primary health care, health promotion, and health security really have to go hand in hand in hand. Having said that, though, getting to better health security is not just a matter of getting to UHC. In fact, in COVID, what we saw is some of the most developed economies and some of those developed health systems, in fact, had critical weaknesses in their public health function. So it's not just more, it's really looking at specifically what are the needs that we have. The other lesson is that we can't solve this just at the global and the regional level. And at the end of the day, all health emergencies begin and end in communities. And it's really there that we need to have that resilience at that primary healthcare level within the communities. And they need to be able to have the tools, the capabilities to be able to both prevent, detect, and respond to emergencies. But they also need to be able to rapidly draw down on subnational, national, regional, and global capacities for support. So we need to work both angles. We need to have stronger, more resilient communities and primary healthcare systems, but we also need to have more responsive subnational, national, regional, and global mechanisms to support that. In terms of the way we're seeing this within WHO, we've had many different reviews, the IPPR, the High-Level Independent Panel, the Working Group on Preparedness and Response. In fact, you could say there's been a bit of an epidemic of reviews and recommendations that really were coming out of COVID. And in fact, we had synthesized more than 300 recommendations coming out of these independent reviews during COVID. And in the EB, the Executive Board at WHO, this year in January, member states asked the Director General to try and synthesize these recommendations and put forward the Secretariat's vision in terms of how to take these recommendations and strengthen the architecture for health emergency preparedness and response. And that's what we did in May. We presented a paper called 10 Proposals for a Safer World, which was really building off those recommendations, synthesizing them, and putting a sort of a coherent framework, a strategic framework of how these things could be taken forward. And we did this in consultation with member states and partners in May, and that we've continued to consult with them over time. And these recommendations came down into three big buckets, one around governance, one around systems, and one around financing. So there was a recognition that we needed to strengthen the governance around health emergency preparedness and response, and this is obviously very much being anchored within the negotiations that are ongoing around the Pandemic Accord or Pandemic Treaty. And that's going to be an incredibly important document in which member states politically will commit to, hopefully, a number of areas of co-action in preparation for detection of and response to pandemics. This is also related to then the strengthening of the international health regulations and an amendment process within that, looking at some of the critical weaknesses, in particular around the implementation of IHR. And so those two tracks are actually going on right now, and the plan is by 2024, so not next year, but the year after, to be able to present a negotiated document and a negotiated accord and a negotiated changes and amendments to the IHR. We've also established now a standing committee for emergencies at the executive board, and that will meet first time in January. And the idea there is to have a mechanism of which member states can quickly call together at the World Health Assembly in times of when there are emergencies, as well as to have a permanent mechanism and agenda committee to be looking at emergency issues as they go through the governance. We're also looking at the rollout of the Universal Health and Preparedness Review, which is a peer-to-peer country review mechanism and accountability mechanism, support mechanism for preparedness. In terms of the systems, and I'll get into a little bit more detail in the next slide on this, we're looking at the capacities, and so this is being covered so far in this meeting in terms of the global health emergency workforce and the emergency workforce. Strengthened coordination, both for preparedness, prevention, and readiness, but also for detection and response, as well as strengthened collaboration around those big areas such as surveillance, which we've talked about, but also community protection, safe and scalable care, access to countermeasures, and then also the collaboration around the coordination. And one of the big areas that we've worked on this year in particular is strengthening the financing around emergency preparedness and response. And we've been working through the G20 Finance and Health Task Force to really set up an ongoing mechanism of dialogue between finance ministers, health ministers, talking about the importance of preparation and response to emergencies and how this has to be adequately financed. And that mechanism will continue into the India G20 and beyond to continue to bring up the agenda items of bringing increased financing into a health emergency and public health, but also looking, as I think was stated this morning, around the broader economic, and we're going to cover it today or tomorrow, the broader economic consequences of emergencies as well. The one big outcome this year from that collaboration has been the establishment of the Pandemic Fund for Preparedness and Response to Pandemics, which has been established at the World Bank with WHO as the technical lead for that. So far, that's capitalized at about 1.6 billion, but hopefully we're hoping very much more that will increase in financing over time. Currently, that pandemic fund, the board has met, it's been formed. The board is now currently working on the final results framework for the fund, the priorities for the first call for proposal and the modalities for the first call for proposals. And we're hoping to get the first call for proposals out in January. We're also currently putting together the technical advisory panel, which will be chaired by WHO for the fund, which will be looking at the technical merits, the programmatic merits, and the impact of the proposals that are being going through the fund before they get to the board for approval. The other big area that I think we need a lot more work on is around financing for response, whether it be the contingency financing to get out of the door very quickly. This was a game changer for WHO when we established our contingency fund for emergencies, which was a 100 million fund that we have available that we can distribute within hours of a new event happening. And I think what we now need to do is extend that kind of mechanism both to partners, but also to have those mechanisms available at the national level where they're not currently available. We also need to look at financing in terms of sustainable financing for response. Currently, as we start to scale response, we go back to the humanitarian appeal model. We go out with an appeal, We get sometimes we get good funding coming from that, sometimes we get no funding coming from that, but it's absolutely not a way to be able to be predictable in scaling a response as it goes across geographic borders and as it scales beyond across populations. We had trialed and used the World Bank PEF mechanism, which was an insurance-backed mechanism, which was trying to fill this space. But because of the triggers of that mechanism of the PEF, often it was just triggering too little money too late. There is other mechanisms that we've got out of the World Bank and some of other agencies, but this is a big space that we need to move into in 2023. The other area that we're finding in financing for response is the at-risk financing for the rapid discovery and development and access to countermeasures, which came in under ACT. But once again, there was no predictable mechanism of scaling that type of financing. So those are two things that we still need to work on. In terms of looking at the systems in more detail, and this has been very interesting in looking at just the presentations that have happened over the last couple of days coming through the public health institutes, what we're looking at is evolving from IHR, which is really the bedrock of those capacities. But what we found in IHR, in not just in COVID, but with other events, is that we're often ending up with capacities, but the inability to actually turn those capacities into effective response capabilities. And an example of this would be having very strong laboratory capacity, but being unable to actually put a testing regime in place, for example. And there's 2 minutes, okay. I think this is the last slide. So as we've gone through the lessons learning of this, we sort of see 5 big areas that we're working on, and we would like to work on, and we are working on with national public health institutes and national governments and partners. One is around collaborative surveillance, which we talked about this morning. So integrated disease, but also threat and vulnerability surveillance, the enhanced laboratories diagnostics, and that collaborative intelligence analytics pulling it together. One area we haven't really touched on, but I know many of the public health institutes are heavily into this, is the community protection, whether it be risk communication, infodemic management, designing those effective public health and social measures, as well as addressing the broader community concerns beyond the public health measures in terms of social protection and livelihood protection. Looking at safe and scalable care in terms of emergency clinical care and being able to surge capacity when we need it, as well as protection of health workers and patients with infection prevention and control, and being able to maintain essential health services during emergencies. The other big area that we're working on is around access to countermeasures, the fast-tracked R&D and development, and pre-negotiated agreements for access, scalable manufacturing, and coordinated supply chains and equitable access. And underpinning this is the coordination, bringing this together through the health emergency workforce, including strengthened national emergency workforce and surge deployment teams, strengthened national action plans for prevention, preparedness, and readiness that are much more dynamic and responding to new threats, as well as the scaling of rapid alert and response coordination, and really looking at a much more standardized way of looking at across countries and within countries. So maybe I'll leave it there, and happy to answer questions.
Thank you very much, Scott. We will save the... Okay, we do it now. Feels very good. It feels very good also to have standing applause,
it does.
right? Yes. Any comment or question to Scott? No, there was... Yes, please. Microphone.
Thank you so much for your presentation. And
please stand up. So
yes, sorry.
Yes.
Thank you so much for your presentation. Thank you so much, Director. Actually, we saw some countries, including I'm from Somalia. My name is Mohammed. So we really appreciate the new initiative for WHO for the health emergency. Yes. This is really shows how important is as part of the COVID-19 pandemic response, what we have learned, and the importance of the components as part of the strengthening, and how we can link to
We got another one?
Yeah, other microphone, please.
Sorry about that.
No, it's okay. And it shows really how important is how we can organize ourselves when it comes to the integration and the linkages between the primary health care and also the different components for the health system is strengthening. And the interventions and the way we were responding for any kind of emergencies. I really appreciate for that effort and how we can strengthening. This is a very good initiative, and how also we can link to the 13 core capacity for IHR, not only just for to wait when the pandemic happened, also how we can, start financing before any kind of incident happening, and how countries can be ready for, making sure that to have any kind of the response funding mechanism. But my question is, apart for all these efforts, we know that we have learned a lot, and any countries now, started how they can restructure or reorganize themselves, how they can, make sure that to be well prepared for any kind of incident. What are the role of WHO in terms of how they can make sure that, because we know that when it comes to we are all now focusing many of the incidents, just how to make a response quickly as much as we can. And we are mobilizing for resources just to respond, without any linkage for the health system strengthening, without any linkage what we have learned previously. And I really appreciate we do a lot of interaction reviews, we do a lot of workshops, but we are looking now what is the impact and how we can make sure to happen for that. Thank you so much.
Yeah, no, this is really the model. I think we've come quite a long way in our ability to structure and then mobilize resources for response. But we now need to do the same thing for preparedness. And I think we have the tools there. We have the JEs, we have the SPA, we have the national action plans. What I don't think we've been able to do effectively is raise financing for that, as well as make the investment case for that, to be honest. So I think often what we do is we identify priority gaps, but we don't really make the investment case of what is it that needs to be invested, how do we invest it, where do we go for the financing. And I think the other difficult thing here is it's not all just going to be additional money, it's also influencing the way we're currently investing in other health projects and systems. And so it's this dual thing where I think there are some essential public health functions that just need more investment, but there's also making sure that we're realigning existing investments that are happening. And there's been a lot of money actually available through the World Bank and through other mechanisms that we haven't been able to leverage well enough. So I think that's really now our focus is around strengthening those national action plans under national leadership. The pandemic fund, we hope, will drive financing into the priority gaps identified by countries, and then leverage the other financing sources that we've got, whether it's the bank, whether it's the C19RM or domestic financing into those investments. So that's what we're definitely hoping to do. And I think this is where we see the huge linkage between IANPHI, the National Public Health Institutes, and this work, because it's a direct role that we need to make that connection. And that's why we're very, very happy with the MOU that we've signed recently in order to be able to make that linkage. And it came up a number of times in discussion already.
Thank you very much, Scott.
Thank you.
Okay, another applause, another raise up. It's time for our next presenter, and that is Annika Veimer. And Annika is the director of the National Institute for Health Development in Estonia. And Annika will present on a report of the 2022 IANPHI Europe meeting. So please, Annika.
Thank you. Which one of them I use? This one. So I was asked to summarize the Tallinn European Network meeting. So I will do that within about 7, maybe 8 minutes. It will be a challenge to do that short overview of the meeting which we had for 2 days. And well, first of all, it's excellent to meet everyone in person. In Tallinn, we tried 3 times to hold a meeting for the European network. First time we had to postpone it. Second time we had an online meeting discussing digital health and COVID. And this year, then we finally managed to have a hybrid meeting with about 50-50% being physically there and online. And we discussed Russian attack on Ukraine and COVID-19. So if I may have the next slide, please. This was the group picture taken on the meeting. So I was thinking I'm not going to put any text on the slide. So this is just the background pictures for my talk. So next slide, please. I would like to use the same metaphor that I used in Tallinn. And this is a puzzle game. Most of you know it. It's a Hungarian fellow called Erno Rubik, developed it in 1947. It's pretty simple. The world record is like few seconds, like 4 or 5 or 6 seconds or something to assemble it. And this is how it used to look. And I stress how it used to look. It was very simple toy, just rearranging the colors in the right squares, and that was it. When you look at today's world, then the cube is quite messy. There is various crises going on in environment, population health, the wars. So the logical pattern is lost, and the 6-second arrangement pattern is also lost. And things are a bit random and out of place. And if you have seen these toys today, the one on the right side, this is how they look. There is a lot more squares, a lot more patterns, a lot more colors. And some have like little triangles growing out of the cube. So we're shifting from one crisis to another, and that was the main theme that we discussed in Tallinn meeting. And the key to success is cooperating and learning from each other. So next slide, please. And the Tallinn meeting was titled Preparing for and Responding to Crisis, What Role for the National Public Health Institutes? We had addresses from the Minister of Health and Labour, Mr. Tanel Kiik, from IANPHI Director Duncan Selby, then European Chair Trygve Ottersen, and also the first keynote was presented by Gerald Rockenstaub, who's the Regional Emergency Director for WHO Europe. And all addresses reflected on the current ongoing and what actually seems to be a permanent state of crisis. Our seminar had 2 major themes. Of course, war in Ukraine and its impacts, and the second one, what COVID taught us on the large scale or a large scheme of things, and how to prepare for the future crisis. So next slide, please. This is a picture of Professor Mark Bellis. He is from Public Health Wales, and he set the context for the meeting on the first day and talked about the health implications of collective violence. We talked about consequences of war, how complex the problem solving has become regarding housing, displaced population, malnutrition, people with from vulnerable groups, people with disabilities, family separation, mentally ill parents, kids who are unaccompanied, etc., exposure to violence. So, and this is not an exclusive list of problems that we're dealing with. And this is all trauma, and in the very broad sense, trauma. And the key takeaway message was that healthcare and health system strengthening is our core issue, but we need to focus more on cooperation between the social and the health systems. And the same goes in Ukraine. There is support that was needed in spring in both social and health systems. There is support which is needed right now and also in coming months. And I think we hear about it in a session coming up in more detail, what the needs are and what the situation is. But there must be both adequate preparation effort to take care of refugees, which requires a lot of international cooperation, but also need to consider medium and long-term perspective. Are the refugees willing to or needing to stay longer? How long will they stay? Polish estimate in May, and that was in May, was that about 85% of refugees want to return home, but today we don't have the answer. What is the situation? We know that in many cases it's just not possible. Next slide, please. Then Dr. Ihor Kuzin, Ukraine's Deputy Minister of Health, described the impact of war on health and Ukrainians and on also national health systems and infrastructure. The main challenge in the beginning was scaling up help for medical supplies and also life-saving supplies and medical staff. There was and still is very high concern on internally displaced people having challenges in receiving vital care, and it becomes increasingly an issue. Also, we had Dr. Jarno Habicht, who is the head of WHO office in Ukraine, discussing public health and Ukrainian war context becoming more complex. Yes, I know. And what kind of technical support is needed. And last but not least, EU accession is the goal in Ukraine, and being EU candidate country, we can help Ukraine with reaching the necessary legal framework. And this need is something to be fulfilled in coming weeks, not months and years. So the second topic, next slide please, very shortly, was COVID. This is something which every one of you has been involved in. And the session lessons learned were first, COVID crisis went beyond direct disease impacts. And second, communication. That it is essential activity in public health, and there was scientific, political, media communication, and we all know what kind of communication frenzy it was. And IANPHI launched the lessons learned, and we discussed yesterday over dinner that it would be interesting to have a very open lessons learned where everyone leaves their laptops and phones outside of the room and then talk about what and how things really happened. So that there's a food for thought for IANPHI. And regarding communication, it's also the question how to involve the community so that the communities don't get tired of the situation, and also about cooperation, how countries communicate between each other, because we saw a very national level and closed down response in the beginning. So this is also a big communication issue. So we need to think what has gone right, also what has gone wrong, and revise preparedness plans for future crises in that regard, and also keeping in mind that it does go beyond health. Next slide, please. And I conclude with Duncan Selby's words in Tallinn that we must also feel good about what we do. And there is a nice picture which actually, there is proof that we felt good about the meeting. And, but it is true not only in the European Network meeting, but globally, and it is very true here over the next 3 days in Stockholm. So thank you, Swedes, very much for hosting.
Thank you very much, Annika. So please, yes, thank you very much, Annika, for that very nice report from the European Network meeting. We will then go on to the 4 case studies, and we will start with Professor Hervé Hien that will present remotely. Very welcome, and the floor is yours, Prof. Hien, who is the Director General of the National Public Health Institute of Burkina Faso. You have met Dr. Hien, Professor and Dr. Hien, yesterday already. Do you hear us, Hien? The floor is yours. We are trying to connect with you. Professor Hien, can you hear us? If so, the floor is yours. Hervé? My French is probably not good enough. Hervé, we can hear you very remotely. Can you try to speak up and very close to the computer so we don't lose? We still do not hear you properly. Yes, and also it will be in French, so you can get ready for the interpretation while we are arranging the technicalities. Can you try again, Hervé? Yes. Please, we need to hear you even louder, And also, we do not see you on the screen. Is your camera on? Prof. Hervé, is your camera on? So should we go on with the next presentation? Meanwhile, we try to sort out the technicalities. Can you try again, Hervé?
Hello?
Hello, yes, we hear you very remotely. Can the interpreter hear? Not quite.
Vous m'entendez bien?
We hear you, but it seems as though you're not speaking in your microphone. So if you have a microphone, if you could please use it, if you have a headset. Okay, now maybe. Try again, Dr. Hurry.
Très bien. Vous m'entendez bien maintenant?
Excellent. Thank you.
Thank you.
Bien.
Bonjour à tous. Désolé pour les quelques secondes de perturbation technique. Moi, c'est Hervé Hien. Je suis le directeur général de l'Institut national de santé publique. Et c'est avec plaisir que je partage avec vous ce cas du Burkina qui va donner un peu quelques éléments sur la contribution d'un Institut national de santé publique dans la gestion de la pandémie 19. Slide, s'il vous plaît. Alors, la présentation va aller très vite avec ces 4 points. Le premier point, il s'agit de donner un peu la prochaine diapositive, c'est de montrer comment l'Institut national de santé publique s'organise actuellement en tant qu'instrument de santé publique au niveau du pays, en tenant compte, bien entendu, des fonctions essentielles de la santé publique qu'un institut doit pouvoir porter. Notre institut est sous le secrétariat général, comme le précise la diapositive suivante, s'il vous plaît. Et au sein de l'Institut, nous avons 4 grosses composantes. La première composante qui est à l'extrême gauche, c'est le centre des opérations de réponse aux urgences sanitaires et ensuite le département de laboratoire central de référence, qui sont les 2 entités, donc le chorus et le département du laboratoire de référence, qui sont les 2 entités qui ont vraiment joué un rôle dans la réponse face à la COVID-19, dont on a fait face depuis 2020 jusqu'à maintenant. Et ensuite, il y a les départements de recherche que nous avons à l'intérieur de cet institut et un observatoire de la santé de la population aussi. Voici 4 instruments de santé publique que nous avons au sein de la structure qui nous ont permis donc de répondre, de contribuer à la réponse face à la COVID-19. Diapositive. Slide. Diapositive. Alors, au niveau national, il faut dire que dès que la COVID est déclarée, en 2019-2020, nous avons eu le schéma suivant à titre d'organisation au niveau national pour faire la riposte. Et vous voyez qu'au niveau le Centre national de la gestion était basé au niveau du premier ministère et l'Institut a joué un rôle très important dans les opérations. Tout ce qui est en rouge, ce sont les 10 opérations qui étaient nécessaires pour aller sur le terrain, telles que la surveillance, le laboratoire, la logistique, la planification, la sécurité, ainsi de suite. Diapositive. À la date du 31 octobre, du du 31 octobre 2022, nous pouvons noter les chiffres suivants. Nous avons à peu près 21 000 sujets qui ont été infectés par la COVID, avec une proportion plus élevée chez les hommes, 13 000 hommes et 395 décès. Et à cette date-là, nous avons 3 régions qui étaient toujours touchées par cette COVID-19, avec donc des cas qui sont progressivement en dégression. Diapositive. Voilà. Donc, vous voyez que tout au long de 2020, de 2021, de 2022, voilà la progression de cette épidémie. Et nous savons que c'est principalement au mois de novembre, décembre, janvier et que les pics sont en train de monter. Comme le voit le montrent les chiffres de l'année 2020 et de l'année 2021. Actuellement, nous n'avons pas encore collecté les données du mois de novembre, renseignées dans la base de données, les données du mois de novembre, octobre et de janvier. Et sinon, ça sera à peu près les mêmes tendances. Diapositive. Pour la vaccination, il faut dire que nous avons à peu près, au cours d'une population totale du Burkina qui est environ de 22 millions, et la proportion des personnes qui ont été vaccinées avec une dose, c'est de 16%. Vous voyez que c'est relativement faible. L'adhésion à la stratégie de vaccination est encore faible, comme dans la plupart de nos pays de l'Afrique de l'Ouest. Et ceux qui ont été complètement vaccinés avec une dose ou 2 doses, nous sommes à environ 12%. Donc, chiffre encore faible et qui montre les efforts que les pays, les INSP doivent pouvoir faire pour augmenter nos capacités de vaccination et d'adhésion de nos populations aux stratégies de vaccination. Diapositive. Quelles sont les bonnes pratiques que je peux montrer à travers cette diapositive? Il faut dire qu'au niveau du laboratoire, nous avons établi le dépistage et un bon système de surveillance et surtout centré sur la détection des variants. Voilà. Et nous suivons, chaque mois, nous avons un site web que l'on publie et on renseigne les variants qu'on identifie. Donc, cette surveillance génomique a été vraiment quelque chose que nous avons généré en collaboration avec les partenaires pour pouvoir établir au sein donc, du pays. Deuxièmement, il faut dire qu'au niveau de notre chorus, de notre système de gestion basé sur l'incident, sur le système de management des incidents, et a permis donc d'activer le chorus et de le positionner au niveau national et même au niveau de la sous-région pour être une structure de formation et d'accompagnement de certains pays qui veulent mettre en place leur chorus. C'est ainsi que nous avons accompagné le Tchad, la Guinée, certaines structures au niveau de la sous-région pour les amener à réfléchir sur la gestion selon donc l'approche incident manager. Troisièmement, nous avons la recherche. Et comme je le disais, dans nos domaines de compétences, nous avons 3 centres de recherche qui sont au sein de l'Institut et au ministère de la Santé. Et ces recherches-là, dès le début de l'épidémie, nous ont permis de proposer à l'autorité une étude de séroprévalence. Et c'est autour de 2000.
Prof. Hervé, are you there?
OK, diapositive.
Yes, now we hear you. Good.
OK, donc en termes de bac, l'avant-dernière, avant. Donc, en termes de bonnes pratiques, il faut savoir que nous avons quand même pu comprendre que notre manière de faire nous a permis d'aller jusqu'au niveau décentralisé pour établir le système de prise en charge de la COVID avec des instruments que nous avons développés au niveau, dès le début donc, de la pandémie. Donc, il y a une dévolution progressive de la prise en charge que nous avons menée avec le leadership de l'INSP pour que les régions et les districts sanitaires puissent s'en approprier. Ensuite, diapositive, la dernière slide, il faut dire que malgré ces succès et ces encouragements, il y a quand même des challenges, des défis. C'est la nécessité des INSP, et sinon de notre INSP, d'occuper les fonctions d'un vrai opérateur essentiel de la santé publique sur le terrain par la production continue des évidences et des interventions qui soient nécessaires et surtout des évidences qui permettent donc de renseigner donc les décideurs au niveau des différents pays. Deuxièmement, le deuxième défi, c'est la nécessité de renforcer pendant la lutte contre les épidémies cette dimension du One Health. On l'a perçu très faiblement pendant donc le développement des interventions contre la COVID. C'est vers la fin que nous avons vu que cette nécessité devrait être prise en compte, mais c'est une question de volonté politique. Ensuite, il y a le développement et l'utilisation par le système de santé des instruments intégrés de surveillance des événements de santé publique qui prennent en compte le contexte des différents pays. Et le contexte du pays, par exemple, comme le Burkina, comme le Mali.
One minute left now.
Yes, c'est les populations déplacées, c'est les populations qui font face aux défis sécuritaires. Et quand on a fait une petite analyse, nous nous sommes rendus compte qu'il y avait à peu près 84 instruments de collecte de données dans le cadre de notre système d'information sanitaire. Et ça posait un problème. Il fallait que l'Institut se repositionne pour critiquer cela et permettre donc au DHS2 de jouer pleinement son rôle au niveau donc, du pays. Et nous avons un besoin que nous avons exprimé pour pouvoir travailler par une analyse cohérente de tous ces besoins pour opérer les instruments intégrés de surveillance. Et enfin, pendant donc la COVID, nous avons pu collecter quand même d'autres sources de maladies, comme par exemple les hépatites E, la gestion du choléra que nous avons pu faire. Et ça, c'est au décours donc, de la surveillance avec l'implication de l'Institut national de santé publique que nous avons pu faire ça. Et je pense que ce sont des leçons apprises et des défis qui étaient importants à montrer et surtout dans le cadre donc, du rôle donc, des instituts nationaux de santé publique qui doivent travailler pour faire face à la COVID-19 et de toutes les épidémies dont les pays font face. Merci beaucoup pour votre attention, malgré les défaillances techniques.
Thank you. Thank you very much. We are having standing applauses here for you in the auditorium. Thank you very much. Yes, so we will then go on in the program, and next speaker will also be online, and it is Oleksandr Mastkov, that is the Deputy Director of the General Public Health Center of the Ministry of Health in Ukraine, and he has had this position since October 2020. So please, if we can have Oleksandr Mastkov with us, who will present on public health systems in Ukraine in wartime, new challenges and new lessons learned. Please, Dr. Oleksandr.
Thank you very much. Good afternoon, dear colleagues, dear guests, and dear friends. First of all, thank you for the possibility to be here and share with you our experience of how we have adjusted our activities to reach the targets and stay productive during the last 9 months. Can you move the slides? Yeah, thanks a lot. So let's start. On the February 24th, around the 5 o'clock in the morning, the explosions woke up the Ukraine. Many families left their homes. And now many families have just returned to their homes, and many have nowhere to return to. And life was divided into before 24th February and after. However, the war of Russia against Ukraine started much earlier than 24th of February this year. This war has been lasting for at least 8 years. We are doing good in our fighting of major health threats, but what do I mean behind these words? Before we relied on the best practices of our European and international counterparts, implemented the latest guidelines and recommendations, and cooperate with international organizations and national non-governmental organizations. Here we were before 24th of February. But any words would be relatively weak when we're talking about what we have faced this date and later. The next slide, please. So what we face now, high human mobility. People flee war, they flee uncertainty, they go west, and the west stretches from Kiev to Cape of Rock and further. People lost links with their doctors and had no idea about the next step in their new places. A lot of logistical issues because the local healthcare facilities, laboratories, and pharmacies experienced drugs and health products shortages. Drugs and health product supplies were at risk of disruption. The main stocks of medicines and health products have almost been depleted. The next slide, please. When we are talking about the shelling and occupation, I will ask you just imagine this situation, because you don't think about the visiting of your family doctor or taking any test or taking any diagnostic procedures when you and your family are under missile attacks, when occupiers are walking on your street. You're just trying to hide in the basement at such moment. One of the main challenges was, and it is now, is the personnel, because Ukrainian health sector lost a significant part of its personnel due to evacuation, internal displacement, and even moving abroad. And as of now, 29 civilian doctors unfortunately were killed and over 100 doctors were injured. Data collection is also one of the big challenges because of lack of personnel, limited internet access to medical information systems, and a lot of security considerations make the data collection algorithm broken. Lack of funding. I mean the drastic change in priorities when some funds assigned to healthcare issues were reallocated to the war needs. Next slide, please. Damage and destroyed infrastructure. It's one of the biggest challenges because Russia destroys Ukrainian infrastructure, in particular healthcare. From the beginning of the war, more than 1,153 healthcare facilities has been damaged or destroyed and stopped functioning of today. But during the same time, we are not stopped at this moment, and during this time we are trying to restore and roll out the functioning of these facilities, and during the 9 months of the war, 98 facilities were fully restored and more than 200 partially. Next slide. And as you see on this slide, this is the data of early July. This is the huge cost for renewing medical infrastructure needed. Why is the July data? Because it's very long procedure to calculate in the proper way the real damages and the cost which will need for the restoring. And this is what we have got. Let's move on and look at how we have managed it. Next slide. Together with the WHO, we have conducted the public health situation analysis and identified, according to this methodology, the top 3 risks, and they are the mental health, injury or trauma, and infections, and radio or nuclear hazards. These risks are not novel ones, but the most urgent to react upon. Next slide. Design thinking is highly popular nowadays. I believe we passed and express course in design thinking when looking for ways to restore clinical, medical and public health services and maintain routine ones and keep the key components of the healthcare system operational. What we have managed? We have managed with mobile clinics that bring the medical care to the most hard-to-reach areas, including newly liberated territories. Mobile vaccination teams are successfully functioning now, ensuring timely vaccination and as much as possible coverage rates given to the current situation. Duly awareness, rising activities and cooperation with stakeholders resulted in broad support for vaccination efforts. For example, even Price advocates the need to get vaccinated. And it was the practice which we started to use during the rollout of the COVID-19 vaccination campaigns, but the real life shows that it helps also during the wartime. The new logistic routes and transportation procedures are being developed to ensure sufficient stocks and delivery of medicines and healthcare products. And also antibiotics are provided from the September via the prescription only, and those containing the spread of AMR in Ukraine. Next slide. And we are not alone. The public health centers relies on newly established regional centers for disease prevention and control that are our hands in the field and international partners near us. We want to thanks to all international partners for giving supports and helping us in development of this area and action. Next slide. In this rather difficult condition, despite Russia's war against Ukraine, our country was able to adopt the law on public health system on the September 6th of 2022. And this law is a new framework for the further building of the proper public health system in Ukraine. Next slide. But this law prescribes also a huge part of work, and we should very quickly elaborate on 85 bylaws. We are also currently working on other normative documents in the field of public health and adapting them to the legislation of the European Union, which is a critical issue for Ukraine. Next slide. The most big problem and the hardest to and one of the hardest things for us is unfortunately the children murders and problems with the providing healthcare to children. But we keep fighting, and we need to know that our most reliable allies continuously support us. Next slide. Thus, we have developed a healthcare specific part of the national recovery plan, identifying the most critical needs. And these needs are related to the infrastructure, technical, professional, and staff areas. Next slide. And thanks to the colleague from Estonia, who is already said about couple of priorities and for the nearest time. Now in the process of Euro integration, we will need the support in the expert and technical help for the creating and establishing the proper legal documents. Also, we will focus in rising up the staff capacity and rising up the skills of our staff members for quick reaction on the public health threats. All these activities will be closely connected with responding of our general challenges. I mean the ensuring of critical or ensuring of proper work of the critical medical infrastructure for providing the medical and public health services. Next slide. And this is our plan for the future, and to if you will ask me what our plans, I will have the very clear answer. Our plans is to achieve our targets based on the developed health strategies in line with the ongoing health reform and the best European practices. In our context, we strive to preserve the well-being of each patient. Next slide. And at the end, I want to say a couple words about these two photos. In the left photo, you can see the one of the streets of Ukraine during the blackouts, which we have each day in our capital, in Kiev, and it would be for 5-6 hours per day and even more. And this is the lights of the lights of the car. And in the right photo, you can see the dependence of time and blackout on our power and law for our military, who protect our children, and law for all colleagues and partners who help us. Thank you for your support and solidarity.
Thank you very much. Thank you very, very much, Oleksandr, for sharing the extreme challenges that you are facing and the enormous impact wartime has on health systems. Also very impressive to see how you have coped with this by restoring clinics, starting mobile practices, hotlines and new ways of transportations, and even implementing a new law and planning for the future. We are so impressed. Thank you again very, very much. We will go on with our third panelist, and I welcome Abdifatah Ahmed, who will present on climate changes. And Dr. Abdifatah is currently the Executive Director of the Somalia National Institute of Health and also the Chair of the Somalia's IDSR Technical Working Group. So please, Abdifatah.
Good evening, and thank you very much. And Somalia has experienced long outstanding humanitarian crisis in the world. And can I have the slides here? Yes. And the humanitarian crisis in Somalia is one of the long-standing in the world, and the climatical shocks have displaced Somalis from their homes. In 2020, nearly 1 million people have been displaced, and also 144 hectares of farmland destroyed. At the same time, for the first time, Somalia experienced the largest locust invasion in 25 years. And also, 50% of the population are affected by drought currently as we speak. 1 million Somali people have been displaced, 84% women, children, and elderly people. Nearly 300,000 people are at risk of catastrophic famine and food insecurity in some regions of Somalia. 1.8 million children are acutely malnourished, and 2.4 million people live in hard-to-reach areas due to insecurity conflicts that is currently ongoing in the country. Next slide. Yes. And can we say that history is repeating itself after time to time, and we see the trends of climatical change repeating since 1992, and famine has, if we go back to 1992, famine killed nearly and displaced 20% of the Somali population, and also extreme floodings up to 1.4 million in 1997 to 1998. And one of the Somali famines that was the worst crisis was whereby 206,000 people died, and the international community delay to respond has really caused the tragic, exacerbated the issue. And the next famine in 2017 was a bit better, and it was mobilized for the support. But as we speak now, the crisis that is ongoing currently might be worse because 4 rainy seasons have failed to produce, to come. And this is in extreme crisis of famine. And according to the statistics at the Somalia APC Technical Working Group, the South Central Somalia and the Bay region, there is a high risk of famine. And as we speak in December, this is, and the government has really declared an emergency on drought response. Well, the COVID-19 pandemic that has really hit the whole world has really tested and exposed the weak health system in Somalia. And the vulnerability has really increased, and there has been a huge disruption in, next slide, in the essential health services. 20% reduction in life-saving vaccination coverage, 4% reduction in facility-based healthcare delivery, and 13% increase in childhood mortality in the country. This has been as a result of the shock of the COVID-19 that has hit the country. Well, I would like to say that despite all these challenges, for the first time in the country, Somalia had the ability, as during when the COVID hit in the country, 20th March 2020, the testing capacity in the country was very low, but when the pandemic was there, we had to act, and with many thanks to WHO, we really managed to have the testing capacity of the country, because we used to send samples to the neighboring countries, but during the COVID-19, the PCR was made available in the country, and I can proudly say that almost in every state of the country, there is a PCR machines that are able to do real-time diagnostics in terms of the COVID-19 and also other diagnosis. And training of laboratory technicians have happened, and also provision of essential drugs, PPEs, and also life-saving oxygen plants. There was time whereby oxygen plants, there was no single oxygen plant in the country, and those was during the first and the second wave. And we managed, at that time I was the incident manager for the COVID-19 pandemic, we managed with support from partners, we managed to secure oxygen plants in the country. And for the first time, we had oxygen plants that were brought to the country, and today, as we speak, we have over 10 to 15 oxygen plants in the country. And this has not only improved to fight COVID-19 pandemic, but also childhood pneumonia. And this has really supported and reduced the mortality rate. Next slide. So you can see here is technicians, and I also forgot to say that not only the PCR testing, but we went to the next step whereby we were able also to do the genomic sequencing in the country. And this has been, with support from our partners, mostly I will say WHO, I would like to really thank that for the technical support during these difficult times. And the staff's capacity have been capacitated, first of all, to do the PCR testing, and that was their first time within those periods. At the same time, going to the next level of the genomic sequencing. And now, the last variant was actually sequenced in the country. You can see here, I want also to thank the Somali private sector for their part. They have, this is one of the Dabshil, they have contributed to oxygen plants in the country. and also oxygen plants both through World Bank and Ministry of Finance government and collaborations. And this has really improved and made the health system resilient. Next slide. I just want to say that climate change is real, and we see the effects in Somalia. And since 1990, and there has been 3 major droughts and locust swarms, and the temperatures, air temperatures in the country has increased to 1.4 to 3.4 by 2080. The sea levels has risen from 36 and 42 centimeters by 2080. This is a projection. And also 1.6 Somalis have been displaced due to continuing humanitarian and crisis as a result of climate change. And this is throughout all the major cities in the country. Next slide. Some of the main projections of climatical shocks in Somalia, more frequent and intense events, and flooding. One time you have extreme droughts, and then soon after you have floodings, high temperatures, and resurgence of diseases attributed to climatical change. Agricultural crop loss, internal displacement, extreme food, hunger, and malnutrition, climatical security impacts. Well, and Somalia is off track when it comes to the SDG, and this is no poverty. This is one of the goals. 69% of the population live below the poverty line. Zero hunger. 79% of the population experience either moderate or severe food insecurity. Good health and well-being. Universal health services coverage is 27 out of 100. And clean water and sanitation, 32% of the people using safe services, 52% of the population are using and safely drinking water. Well, the climatical change, and as you can see from my presentation here, that Somalia is off the track when it comes to the SDG. Next slide. And health systems suffer if food systems are not working. And food insecurity results in malnutrition and also increased mortality rate. And this is also the increased risk of health risk. And all this is a cycle that the country is currently experiencing. The impacts of the droughts in the country, 4 to 5% in childhood diseases like measles and cholera, increase in severe and acute malnutrition, extreme hunger. And also, according to the statistics, 7 out of 10 Somalis live below the poverty line of $1.9 a day. This is, we have a population of IDPs within the cities, increased and vulnerability to the whole population, and more so women, youth, and children. And also, the vulnerability has been ongoing. On top of that is a coupled insecurity. So the hard to reach areas and the climate, all these factors are contributing to a stagnation. Well, these are some of the recommendations to intensify multi-sectoral efforts to combat the effect of climate change, support in scaling up social protection programs, and also help in building a resilient health systems that will be able to cope up with the changing of climatical change, and promoting durable solutions that benefit the population in displacement settings by strengthening resilience and avoiding negative impacts on critical livelihoods and natural resources. Advocate for inclusion of women and youth in this as a food system. So this is short presentation from my side, so thank you.
Thank you so much. Thank you very much, Abdifatah, for sharing also on your account extreme challenges with many years of conflicts, but also droughts and floods, famine and displacements. Very impressive to see the ambitions you have for public health. We will go on to the fourth and last presenter, and this is Mariken Leurs, that will present on the added value of behavioral sciences, lessons learned from the COVID-19 pandemic. And Mariken is the Director of Health and Society and head of the Corona Behavioral Unit at RIV-M. Very much welcome.
Thank you very much. And I have to say, I feel very humble and almost ashamed speaking now, because the stories we just heard are so impressive. Coming from the Netherlands, I feel the pain, and I'm very sorry. That I hope we can contribute more from Europe. But I was asked to talk to you about the lessons learned we did in COVID in the Netherlands. So I'll try to bring you to the lessons we learned and we're learning at the moment. I'll take you back to March 2020. I was just told with my center to work from home by our Prime Minister, and we were sitting at home, whereas our infectious diseases colleagues were really working hard. And that was the moment that my Director General, Hans Burg, who couldn't be here, and I'm his replacement, he asked me, does it work? Yes. On the 19th of March, he asked me, Mariken, this is about behavior. You're a behavioral scientist. What can you do? And I contacted two other professors in the country who were already active on social media. One I had met before, one I'd never met before. I asked them, we need you at the Public Health Institute. We didn't have any behavioral network already going. They came the next day. And the next day, we really started asking everyone with a behavioral science background within the institute to come together, be from the environmental side, from the public health side. And we thought, what do we have to do to really start helping? And what we did is, first thing, we said we do have to have our theory in place. And all the factors on this scheme may seem familiar to you. We were really focusing on what are the determinants of behavior change in the short run, but realizing that it may be also taking a longer time, so we have to look at adherence as well. And what we did with the theoretical framework was putting it into a large survey. And I never experienced this before, but within a week time, we had the money, we had 25, all the regional public health institutes working with us. We put out a large survey, and we had 90,000 people all over the Netherlands participating, and we asked them also if they wanted to join continuing. And 60,000 did. So after the end of April, we had 50 to 60,000 people responding every 3 weeks on a lot of different aspects. So we looked into the behavior side of it, things, of the measures, the beliefs they had, does it work or not, also the effect. So I'm not going to in all the slides, and all the slides will be available later on, but it did give us feedback in how people were responding and how different age groups were responding. Also, we looked at well-being, because in the first instance, we thought, oh, this is going to hit the elderly very hard. But we very quickly saw that it was hitting the younger population. So the pink line is the younger population. The top ones is about loneliness, feelings of loneliness. And over the 2 years, we saw that the younger population was affected much harder, and they felt much more lonely. And they haven't come back to the situation prior. And below is the mental health inventory scale. And we saw it very much changing over age groups. We also looked at trust and procedural justice, because we also learned from data that this may be of some effect. And we now see a very clear link between trust in corona policy and vaccination uptake. And we have to do more analysis in cause and effect, but there are some interesting patterns appearing. But we didn't do only surveys. We felt the need to go behind the numbers. And after every survey, we had interviews, telephone interviews with 60 people, an hour long, to go into depth in some of the issues we saw appearing. And we also, from the open text codes, we had 1,000 every survey, which we coded and tried to find the story behind. But also looking into interventions, going into the field and getting narratives of cafes and bars, of student homes, of schools, youth care. How does civil society respond? How do managers respond? What positions are they taking? And last but not least, we've started looking into the preferences of civilians. Because in the first, well, a lot of the COVID was aiming at reducing death. But it came, a cost was put in different places. And how do we weigh these different things? What we also realized and what we noticed, because as a behavioral unit, we weren't part of the crisis scheme in the Netherlands. We were not part and included in the outbreak management team. We didn't have a direct line to the ministers, the decision makers. So we decided from early on we have to publish everything. We are very transparent on our results. We started using social media. From the Public Health Institute, we couldn't interfere or participate in public debates on TV, but we had 15 professors joining us as our advisory board, and they could. So we made sure that they got all the data and information so they could share more the knowledge about using behavioral insights. And we came up with this. This is not a scientific model, but this is a talking poster, because we realized that we felt a lot was focusing on communication, press conferences, and the general belief was if we tell the people what to do, they will do it. But that doesn't, well, the first week they did. But you have to look also into different things. So communication is not only about agenda setting, providing the right information and making sure that the information in all the different media platforms is the same. Knowing how to motivate people. People weren't motivated by preventing their own health. They were motivating and caring for others. They wanted to protect the people they love. So that's a more motivating factor. But also looking at context. That's why we came up with the 3C model, because we said, think about communication, context. How is your physical environment adapting to providing space for people to keep distance? But also, how's your social environment? And what facilitation do you have in place? Do you still require students to come to take the test physically at the schools or their exams? Can they do it another way, or do they fail a full year? Is there a financial support structure for people with small businesses so they can close down and still survive? So you really have to think through. And then the control part. It's not only about law enforcement, which we, of course, also faced when we had the curfew in the Netherlands. But it's also about very clear about the rules and being able to push things forward. So talk about control is a more elaborate thing to do as well. And this helped us because now we say the 3C model, think about also the context and the control, not only about communication. It's more than just communication. So I'm coming to closing my speech because it was a long afternoon. I think the first two things is what I really would like to share with you, that it is very important to give voice to the silent majority. In social media, you have a lot of people speaking up about anti-vaccination, about complot, about very lively. But we found the majority of population is really willing to cooperate. They see the added value of strategies. And those numbers, they helped also politicians to take the measures they needed to take. But the thing we weren't so good at yet is team up with civil society. When we did all the narratives, and we're now getting all the lessons learned from the narratives, is that a lot of people, directors, managers, people in different positions in organizations, wanted to have more guidelines on how they could still work at the aims of their organization, but also keeping in with a corona policy. And at a national level, you can't think about the specifications for every single situation. So you have, for example, we had in the Netherlands the rule that only 2 people could visit a shop, regardless if it was a small shop or a big shopping department. So you have to really see how you can work with these. There's a lot more to be said, and I'll share all the slides later on. But for us, a major thing, and yesterday it was said, we panic and we forget. In several reviews of WHO in the past, it has been said that we need to include behavioral scientists in outbreak management. Well, let's do it this time. Let's start doing it. And so much more. And now let's dance.
Thank you very much, Mariken.
You're welcome.
And thank you to all our speakers online and here with us in Stockholm. And as Duncan was saying in his introductory speak, and as we've heard throughout these days, not to panic and forget, but rather to learn and build back stronger. So thank you again, all the speakers, for sharing your experiences, your lessons learned. And I think we all can agree on that a resilient and robust public health globally will be the best preparedness for any forthcoming crisis.